All right, so we're going to talk about the environmental emergency section of med emergencies as we're going forward here. And let's get the lecture started. Environmental emergencies are medical conditions that are caused or worsened by the weather, terrain, the plants or animals that are around there, or it could potentially be unique atmospheric conditions that are present at high altitudes or even underwater. Now, most EMS providers would recognize the obvious problem of a child that's fallen into an icy lake. The challenge lies in recognizing patients with environmental emergencies in unusual settings such as like Tough Mudder events, mass gatherings, and in populations who present with complicated physiological dynamics such as a geriatric patient who takes multiple different types of medications. Environmental emergencies involve conditions like wind, rain, snow, temperature extremes, and humidity that complicate treatment and transport. Wilderness EMS addresses medical care in challenging locations defined by planned delivery of wilderness medicine by formal providers, such as Professor Pfeiffer. Even urban areas can become wilderness EMS environments during major storms, such as hurricanes, tornadoes, ice storms, things along that line. And that's typically why it's called wilderness medicine and austere medicine. Certain conditions like diabetes, cardiac and lung diseases, thyroid issues, and psychiatric illnesses can hinder the body's ability to handle severe environmental extremes and changes. Young and older individuals, as well as dehydrated patients, are particularly vulnerable. Overall health, fitness, and acclimatization ability are crucial for survival in such emergencies. Homeostasis balances the body's needs with thermosensitive neurons in the anterior hypothalamus regulating thermoregulation. Now, the hypothalamus acts kind of like a thermostat, adjusting mechanisms to increase or decrease body temperature. The core body temperature, also known as CBT, involves the heart, the lungs, the brain, and the abdominal organs. Increases in the core body temperature will trigger heat loss, while decreases will prompt heat production and conservation measures. The body maintains a core temp of about 98.6, that's 37 degrees centigrade for normal metabolism. The core temperatures will remain constant, while the peripheral temperatures in the arms and legs will fluctuate, and this helps in aiding thermal regulation. Hypothermia starts at about 95 degrees Fahrenheit, 35 degrees centigrade, and hyperthermia starts at 100.4 degrees Fahrenheit and 38 degrees centigrade. Oral temperatures can be really inaccurate. Rectal thermometers are the most accurate for measuring core body temp. The hypothalamus regulates thermoregulation via the sympathetic and the parasympathetic nervous systems. Peripheral and central thermoreceptors relay temperature information to the hypothalamus. At rest, heat is produced by nutrient metabolism, mainly found in the liver and the muscles in the form of glucose. BMR varies by factors like age and body surface area. Exertion, we know, increases heat production. The skin plays a crucial role in temperature regulation, with blood flow reaching up to 8 liters a minute to release heat when the body is getting warm. Thermolysis involves releasing stored heat from the body. Increased core body temperature triggers the hypothalamus to signal vasodilation and sweating. The warm blood cools through radiation, conduction, convection, and evaporation, primarily through our sweat. Radiation accounts for about 65% of heat loss. Conduction transfers heat via contact. Convection involves moving air, and evaporation converts liquid to a gas, aiding in cooling. The only way the body can dissipate heat when the ambient temperature approaches the body temp is by the evaporation of sweat. And this only works up to a point. For those of us that live in the South, we know this very well because of our humidity. A healthy adult can sweat at a maximum rate of about 2 liters per hour. However, the body cannot maintain this rate and can't absorb enough water to replace this loss. At the most, the body can absorb about 1 liter per hour of water, but only in the most extreme heat and humidity. Furthermore, for effective evaporation of sweat, the ambient air must be relatively unsaturated with water. Hard to find in July and August in Kentucky. As the relative humidity increases, the rate of evaporation decreases. Effective sweat evaporation ceases when the relative humidity hits about 75%. Thermogenesis, on the other hand, is the body's ability and method of producing heat to combat cold stressors. Again, the skin acts as a thermostat, triggering shivering even if the core body temp has not been lowered. The hypothalamus and sympathetic nervous systems increase muscle tone, shivering, thyroid levels, and peripheral vasoconstriction. Specific types of sweat glands will now begin to reduce sweating, and thicker outer shells provide better insulation. Heavier individuals, such as myself, are more insulated from the cold. Heat illness arises from inadequate thermolysis, causing the core body temp to rise, often due to hot and humid conditions. Factors like health, appropriate clothing, the ability to move around, extremes of age, and other comorbidities and medications can exacerbate the issue. When the thermoregulatory system fails, core body temp can rapidly increase to around 106 Fahrenheit, 41 degrees centigrade, as seen in heat stroke. Older adults are particularly vulnerable to heat stress due to reduced perspiration, slower acclimatization, less thirst response, and decreased mobility. Chronic conditions like diabetes, cardiovascular disease, along with the medications that these patients take for these conditions, can further disrupt normal heat regulation, increasing the risk of ill effects from heat stress. Medications like diuretics and beta blockers can impair temperature regulation, increasing heat stress risk. Acclimatization reduces heat illness risk but requires days of controlled exertion in the heat itself. Infants, young children, athletes, and military recruits are particularly vulnerable due to higher metabolic heat production and less efficient heat dissipation. Heat cramps are painful muscle spasms caused by profuse sweating and sodium loss. Factors include salt depletion, dehydration, and muscle fatigue. They often affect athletes, military personnel, and laborers. Drinking plain water doesn't replace lost sodium, so electrolyte solutions are crucial, especially if you're providing support services in hot environments such as firegrounds, mass endurance events, or races like marathons. Heat cramps usually start suddenly during strenuous or prolonged physical activity. They may be mild, characterized by only slight abdominal cramping and tingling in the extremities. More often, however, the patient presents with really severe pain in the extremities and the abdominal area and may have nausea along with vomiting. Patients with heat cramps typically do not have any type of an altered mental status. Now, in order to treat these heat cramps, move the patient to a cool space and have them rest if they feel dizzy. Provide electrolyte fluids orally and don't give them salt tablets. Use IV fluids if the patient is nauseated and resume activity cautiously. Heat syncope is an orthostatic syncopal episode occurring in non-acclimated individuals under heat stress, often due to prolonged standing or sudden changes in posture. You can quite frequently see this in high school and sometimes even college kids that are away at band camp out in the summer. Maybe they're not used to the heat and they're standing at attention, or they've been marching for a long time, and then all of a sudden they just simply begin to have syncopal episodes and pass out. Now, again, older adults are at higher risk. Treatment involves placing the patient in a supine position and replacing fluid deficits if the blood pressure doesn't stabilize. Now, if you don't get a relatively rapid recovery with fluid replacement, look for other causes of this condition. Heat exhaustion is a milder form of heat illness, leading to heat stroke characterized by volume depletion and heat stress. It's got two types. We have water depleted that affects geriatric patients and active individuals who don't replace fluids, and sodium depleted from sweating and drinking only plain water. Exercise-associated hyponatremia, or EAH, involves acute serum sodium decrease during or after prolonged physical activity with elevated vasopressin levels. Be alert for older adults and endurance athletes who are at risk for this. At this point, I would tell you to go back and to review a little bit about the role that sodium, as well as potassium, plays in muscle contraction. Heat exhaustion symptoms involve headache, fatigue, weakness, dizziness, nausea, vomiting, and abdominal cramping. Patients are usually sweating profusely, have clammy skin, and may have a normal or slightly elevated core temp. Tachycardia, fast shallow respirations, and orthostatic hypotension are common. Brown urine may indicate rhabdomyolysis, so you really want to watch that. It's easy to misdiagnose this as a person who just has flu in the summer or potentially like a GI infection. So be careful that you take in all the information and make the most accurate diagnosis that you can. Untreated heat exhaustion can produce and progress on to heat stroke. EAH is often asymptomatic but can cause severe symptoms like confusion and seizures, leading to serious complications if it is left untreated. Now, in order to treat heat exhaustion, the first thing we got to do is we got to get these folks out of the hot environment and into a cooler one. Get off the excessive clothing. You don't have to get them trauma naked, but you do need to get the outer shell of clothing off and put them in a supine position where they don't have to worry about falling. If the temperature is elevated, sponge, spray, or drip tepid water and fan gently. But what we don't want to do is we don't want to cool them so rapidly that now they begin to start shivering, thus leading into problems with heat generation. Now, you can use oral hydration solutions with no more than 6% carbohydrate, or mix 1 teaspoon of salt and 2 tablespoons of sugar with a quart of water. If your patient has nausea and vomiting, we don't give them anything by mouth. Now we're going to start a line of normal saline. If EAH is suspected, just don't give them any oral fluids. Watch the blood sodium if you're working in an ER. And if not, just go ahead and give the patient an IV of normal saline. Watch your patient's cardiac rhythm in particular, because remember that sodium-potassium pump. Review their vital signs, the temperature, as well as you should always get a blood glucose on these folks. Use a thermometer to differentiate between heat exhaustion and heat stroke, and consider giving the patient antiemetics like Zofran if they need it. Rapid transport to the emergency department may be necessary based on the symptoms and the history, as well as to help to prevent this progression on into definitely a life-threatening condition known as heat stroke. Now, again, this moves us into heat stroke. It is the deadliest heat illness caused by severe disturbance in the regulatory system of the body to be able to maintain or to dissipate heat. It's got an incredibly high mortality rate. 10% of the patients that you're going to treat are going to die, and anywhere from 30 to 80% in untreated patients will die. Diagnosis relies on elevated core temp and altered mental status. Some of the physiologic effects that you can see include the cell membrane disruption, which releases potassium and sodium into the body, enzyme breakdown, muscle cell damage leading to rhabdomyolysis and electrolyte disturbances. This ultimately causes edema, hemorrhage, decreased cardiac output, a drop in blood pressure, and shock for our patient. Classic heat stroke, often occurring during heat waves with high humidity, affects the very old, the very young, those with reduced mobility, and people in poorly ventilated homes. Those with alcohol use disorder, chronic illnesses or diseases that affect sweating, or take medications that may affect sweating are at much higher risk. Initially, thermolysis or the offloading of heat occurs, but as dehydration worsens, heat dissipation begins to fail, core body temp rises, and sweating stops, leading to heat stroke symptoms. Exertional heat stroke occurs in people exercising in hot and humid conditions. When ambient temperature nears body temp, radiation and convection fail to shed the excess heat. If the humidity exceeds 75%, evaporative cooling becomes ineffective or even impossible. Sometimes these patients will continue to try to push through and continue to exercise, and as a result of this, it generates more heat without release, causing a rapid rise in the core body temp. Commonly affects athletes, military recruits, firefighters because of their heavy gear, and others in intense prolonged activity. Both types of heat stroke share similar signs and symptoms, and they're often unrecognized as heat-related. Now, these patients will often be confused, delirious, or even comatose. They're going to be difficult to give you any type of a coherent history. Early signs include behavioral changes like irritability, combativeness, or hallucinations that can potentially mislead you into thinking you've got something else that is going on. Older adults may show stroke-like symptoms. CNS disturbances such as seizures and constricted pupils are key diagnostic indicators distinguishing heat stroke from heat exhaustion. Heat stroke diagnosis involves a markedly elevated body temp, usually over 104, though it can be misleading if cooling techniques are used. Signs include tachycardia, hyperventilation, and lower peripheral vascular resistance. Dehydration worsens the condition. Now, this is important. Skin may be dry, flushed, and hot in classic heat stroke, or pallor and excessive sweating in exertional heat stroke. In the past, we used to say, well, heat stroke always had dry, hot skin. No, not true. Elevated temperature and altered mental status are key indicators. Always assess temperature as part of the vital signs to avoid misdiagnosis. If you're unsure about the cause of elevated temperature, treat for heat stroke due to its deadly consequences. Online MedControl can assist with treatment plans if you're not entirely sure, and don't be afraid to call them. Rapid intervention is crucial to maintain and minimize organ injury or death. Guidelines emphasize rapid cooling first and then transport. Let me say that again. Cool your patient off first and then get them en route to the hospital. So what do? Well, obviously, we evaluate our initial assessment, airway, breathing, circulation. We're going to give them supplemental oxygen, and we're going to consider sedation if they're agitated or combative. Be prepared to manage the airway in whatever way, shape, or form that you would need. Get them moved into a cool environment. Get their clothing off. Again, trauma naked. Limit their exertion. Make sure that again, this is where sedation comes into play. If they're fighting you, you've got to calm them down. And we're going to begin rapid cooling until the core body temp is below 102.2. The best way to do this is full body immersion into cold water. Watch them, obviously, because we don't want to overcool them to the point that they're going to begin to shiver. Most of the time in heat stroke, that's not going to be an issue. Cool rapidly using the most effective means available. As I said just a moment ago, cold water immersion is the most effective technique. And the way you do this is you immerse the patient from the neck down in cool to cold water until the core body temp is below 102.2. You might want to remember that temp, or neurological symptoms begin to resolve. Monitor the airway and watch for seizures. Other methods include spraying with a cool mist, using fans, cold showers, ice sheets and towels, Cooling vests and jackets, commercial ice packs are a combination of all of them. Start an IV and give normal saline. Do not give lactated ringers because in the hyperthermic patient, the liver cannot process lactated ringers. So we're going to start with normal saline. Again, check blood sugar and be cautious with fluids to avoid pulmonary edema, especially flash pulmonary edema. Cooling can raise the blood pressure due to peripheral vasoconstriction. Monitor your cardiac rhythm and be aware of rhabdomyolysis and hyperkalemia, especially watch those peaked T-waves. If your patient begins to seize, give them a benzo to stop that seizure, and then you can begin rapid transport to the hospital. Cold injuries, on the other hand, now we're going to the other extreme, often affect extremities and expose body parts like ears, nose, cheeks, fingers, and toes. Frostbite is an ischemic injury. It can be superficial, partial thickness, or full thickness, just like other burns. Mild frostbite or frost nip causes numbness and is treated by warming the area. Severe frostbite involves tissue freezing, and this leads to cellular damage and ischemic injury that can be permanent. The most common symptoms of superficial frostbite is an altered sensation, numbness, tingling, or burning. The skin typically begins to appear white and waxy and can often have kind of a hard sensation to it. Because it's frozen, the skin is firm to palpation, but the underlying tissues continue to remain soft. Once thawing occurs, the injured area will begin to turn cyanotic, and the patient will experience a burning, stinging sensation. Capillary leakage produces edema in the frostbitten area, though the development of blisters is more characteristic of deep frostbite rather than superficial. Dull or throbbing pain may persist for days or weeks after the injury. Don't be afraid to use analgesics to address the pain if it becomes severe. Deep frostbite typically affects hands or feet, appearing white, yellow-white, or mottled blue and white, feeling hard, cold, and numb. Now, in this situation, major tissue damage occurs during thawing, especially if refreezing happens, causing larger ice crystals and greater damage. Thawed tissues turn purple and become extremely painful. This is why it's critically important that if you're dealing with a patient with deep frostbite, that if there's any possibility of the tissue refreezing, don't thaw it out until you get them into definitive care. As a result, gangrene may develop, potentially requiring amputation. Pre-hospital treatment for superficial and deep frostbite is similar. Determining injury depth initially is challenging, and we don't really need to worry about that too terribly much. Rewarming can intensify the pain due to a reperfusion injury. Key factors include how far you are away from the hospital and whether the area that is frozen will thaw before arrival. If it's still frozen, typically leave it frozen until you get to the hospital. Consult medical control if you've got any questions on this. The big thing we're looking at here is, again, for all rewarming, is get them out of the extreme environment. You got to get these wet clothing off. Okay, so that's going to lead into generalized hypothermia. Now, you may have heard this, but don't rub or massage the frozen area. If you do that, the crystals are very sharp in between the cells, and literally it will cause damage to those cells, which can lead into gangrene. Elevate the injured area and pad around it, because especially if it begins to thaw out, now it's going to begin to become really painful. Use pain medicine if needed, especially if it begins to thaw. Don't rupture or break any of the blisters that you see on the extremity. And again, the last thing on here, critically important, is that rewarm the patient, and you're okay to rewarm it if you're en route to the hospital and there's no possibility. Again, no possibility of that extremity beginning to refreeze. Hypothermia is defined as a decrease in core body temperature starting at 95 degrees Fahrenheit or 35 degrees centigrade due to inadequate thermogenesis or excess cold stress. It can happen in even mild conditions, such as a geriatric patient in a 60-degree home, especially if the patient is immobile and lying in urine. The body responds to cold by increasing thermogenesis, decreasing thermolysis, and behavioral changes. Vasoconstriction leads to peripheral tissue ischemia, and continued cold causes shivering. Prolonged exposure results in vasodilation and loss of core heat to the periphery. Take a look at this slide here and become very familiar with these different factors that increase heat loss that basically cause an impairment of the regulatory process, as well as disease processes or other things that can cause hypothermia to occur, especially in the very young and the very old. Now, hypothermia, again, is defined as a decrease in core body temp. Now, the National Institute of Health's UMBLS campaign highlights early hypothermia signs: stumbles, mumbles, fumbles, grumbles, and crumbles. Several different guidelines classify hypothermia as mild, moderate, or severe based upon the core body temp. Now, keep in mind that hypothermia can be acute or chronic, as well as primary or secondary based upon the cause. In mild hypothermia, shivering and the umbles, fumbles, stumbles, mumbles, grumbles, and crumbles are noticeable in these patients. Initial symptoms can be vague, especially in older adults who may show confusion or stroke-like symptoms, or in somebody that may have had a little bit of alcohol. Hypothermia slows down body functions, particularly in the central nervous system, that can affect thinking, speech, coordination. These signs, again, can often resemble a stroke, a head injury, some types of psychiatric illnesses, or even alcohol intoxication, leading to misdiagnosis on our part. Peripheral vasoconstriction shunts blood to the core, leading to cold diuresis and increased blood viscosity. In other words, the blood becomes thicker, and when thick blood is in the body, it does not circulate well, and it can cause a relative hypovolemia. Initially, the heart rate increases, then it begins to slow, disrupting the electrical system. Around a body temp of 90 degrees Fahrenheit, cardiac dysrhythmias like atrial fib occur, and at 82.4, now the heart becomes really susceptible to VFib. The hypothermic heart may be unresponsive to any of your medicines, to your pacemaker, or even to defibrillation. Follow rewarming strategies and standard ACLS recommendations, including vasopressor administration like epinephrine for your hypothermic cardiac arrest patients. Let's look at the respiratory system as far as your assessment. Initially, cold increases respiratory rate, but later it slows, reducing your minute volume. Tracheobronchial secretions and bronchospasm may occur, reducing the lumen through which the bronchi is able to get air in. Non-cardiogenic pulmonary edema is possible, especially in older adults. At 90 degrees Fahrenheit, hypoventilation is profound, airway reflexes decline, and O2 consumption decreases by half. As far as the muscular system goes, cold initially causes shivering, raising core temp by around 2 degrees Fahrenheit per hour. Then the shivering begins to stop around 91 degrees Fahrenheit, leading to weaker, stiff muscles and impairing the patient's ability to take care of themselves and get themselves out of the situation. This is why it's not unusual to see geriatric patients near the front door of their home during severe weather. Cold will now begin to deplete glucose, causing hypoglycemia. Insulin levels fall, switching metabolism over to the metabolism of fat. Drug metabolism slows, prolonging medication effects. That's important to keep in mind. Now, you will see some unique changes on your EKG known as an Osborne wave. You may hear it also referred to as the J wave, and it's a positive inflection seen at the J point on an EKG, typically in lead V1. It's most commonly associated with hypothermia and becomes more prominent as the body temp begins to decrease. Now, and you may want to know this both for your practice as well as for exams. The presence of Osborne waves is a key indicator in diagnosing hypothermia, as their amplitude is directly proportional to the severity of the condition. This makes Osborne waves crucial for timely and accurate assessment in hypothermic patients. So how do we deal with this? Well, obviously, the first thing we got to do is we got to get the wet garments off of the patient. That just simply accelerates the process by which the patient is losing heat. Then we've got to protect against what heat loss that the patient is generating by putting blankets and insulating materials on the patient. It's key that you avoid rough movement on your patient. Bumping a patient, jarring the patient, hitting a pothole at 45 miles an hour could potentially put your patient into ventricular fibrillation because the heart is really, really irritable. So there's two routes that we take as far as hypothermia. So first of all, if the patient has got a pulse, we try to determine what is the core body temp. So if they're in mild hypothermia, we want to provide passive rewarming. We want the patient to kind of rewarm itself. If the patient has no nausea or vomiting, we can give them some warm oral fluids with some simple sugars. We can turn the heat up in the back of our truck to help them to begin to warm. If they are in moderate hypothermia, now what we want to do is we want to start with the external rewarming. We want big heat packs, electric blankets, forced air warming blankets. Now again, one of the things I want to caution you is if you use heat packs, especially on the very young or very old, you want to put some type of a barrier between the heat pack and the skin in order to minimize any kind of problem that the heat pack may bring about as far as burns to the patient. If you've got severe hypothermia, basically what we're going to have to do is we're going to have to do internal rewarming. That's going to be done in the hospital where the patient is going to get really, really warmed IV fluids. And we're going to continue that until we get a core body temp of 95 or more. Remember, with your patients, and we'll talk more about this in cardiac arrest coming up with the next slide, your patient is not dead until they are warm and dead. Now, it's key to remember, as the slide says, that simply because you've got signs of death does not come into play for your severely hypothermic patients. Now, there are times that, for example, if you've got injuries that are not able to sustain life, you're definitely not going to try to start that. But again, it extends it on out because of the amount of cold that the patient has had. If your patient's got a shockable rhythm, defibrillate and start CPR right away. Continue on with standard ACLS protocols, including your epinephrine. But again, keep in mind that passageway of the epinephrine is maybe slowed simply because the vasculature is not moving along. If you have a heater, an IV heater on your truck, go ahead and infuse warm normal saline for these patients. Again, we don't want to administer lactated ringers because the liver in heat extremes does not metabolize it very well. Continue to resuscitate your patient. Again, once you've started, this is not a time that you're going to stop until you get to the hospital or you get ROSC. So let's talk about drowning. In 2002, the First World Congress on Drowning defined drowning as an experiencing respiratory impairment from submersion or immersion in liquid. This definition is the current standard in medical science and clinical care. Drowning outcomes include death, morbidity, and no morbidity. Terms like near drowning, wet, dry, and secondary drowning are old and outdated, and we don't use them anymore because we don't change up how we're going to treat these particular patients. People may live or die based on what happens when a liquid-air interface occurs at the glottic opening. Consequently, the drowning continuum progresses from breath-holding to laryngeal spasm to the accumulation of carbon dioxide and the inability to oxygenate the lungs, to subsequent respiratory failure and cardiac arrest from multiple organ failure due to tissue hypoxia. Now, your patient can be resuscitated at any point along this particular continuum, and generally speaking, the earlier the resuscitation takes place, the better the success rate is. Drowning generally will follow a predictable pattern and sequence that begins when the victim cannot keep their face out of whatever liquid that they're in. The length of breath holding depends upon the victim's state of health and fitness, their level of panic. The water temperature plays a key role in here as well. But the thing you got to remember is the duration of breath holding is shorter in colder water. As water enters the mouth and nose, coughing and gasping begin, and the patient may swallow considerable amounts of water. Now, there are some theoretical differences that distinguish saltwater from freshwater drownings. Basically, for us, this is not clinically useful when we're resuscitating patients, so we really don't care. Both freshwater and saltwater can lead to pulmonary injuries, especially pulmonary edema, but the water composition does not significantly affect the electrolytes or the blood volume as what was thought several years ago. After coughing and gasping, drowning can follow two paths, either laryngeal spasm or aspiration. If a patient begins to have a laryngeal spasm, water in the pharynx and the larynx causes the larynx to begin to spasm, leading to asphyxia with a reduction in oxygen in the blood, as well as a sudden rise in the amount of CO2. This comes about and results in unresponsiveness, anaerobic metabolism, lactate production, and metabolic acidosis. Eventually, the laryngeal spasm will relax, allowing water into the lungs. If I go down the aspiration path, water enters the lungs before laryngeal spasm, washing away surfactant. Now remember, surfactant is necessary to keep our alveoli inflated. Deflated alveoli do not provide for gas exchange. This leads to asphyxia. Terms like wet and dry drowning, again, like I said earlier, we don't use those terms anymore. They really don't exist. In the drowning pathophysiology, hypoxia occurs due to apnea. Over time, acute lung injury begins to develop, damaging lung tissue through biochemical processes, including membrane dysfunction and surfactant damage that causes collapse of the alveoli. This leads to fluid-filled air spaces, collapse of the alveoli, poor lung compliance, and really, really difficult problems ventilating and oxygenating the patient, resulting in a hypoxic damage to the brain. Hypoxia will also affect the heart, causing multiple different types of dysrhythmias and ultimately cardiac arrest. Now, in order to assess a drowning patient, specialized water training is essential. You may be part of a fire department. You may be part of, I know at least one EMS agency in central Kentucky has a specialized water rescue team. I believe that's Georgetown, Scott County. But again, the thing here is if you are not trained and have the equipment, you don't want to go. Your training should match the environment that you work in, such as swift water, open water, or even like the ocean with the surf, each with its unique rescue standards and techniques. If you're untrained, and this is going to be hard to do, and you're going to face a lot of criticism for it, don't go into the water. Instead, use techniques like reaches and throws to access a responsive patient. Once you get to a drowning victim, follow the ABCs. Nothing changes in that. Establish the airway first. Clear it out if you need to. Cervical spine precautions are generally unnecessary unless there's a history of diving, some type of injury, signs or symptoms, or alcohol is involved. Patients without a pulse should be moved to a firm surface before beginning CPR. Once on a firm surface, prioritize oxygenation and ventilation using high-flow oxygen for distressed awake patients and immediate ventilation for those who have significant respiratory impairment or those that are not breathing at all. Continue your rescue breathing until the patient is on land. Once on a solid surface, start your supplemental oxygen and check for a pulse. Again, follow your traditional airway breathing and circulation for submersion cases. After 2 breaths, start chest compressions per ACLS and pediatric ALS guidelines. Get a line started, give epinephrine, perform cardiac monitoring, and defibrillate shockable rhythms. One of the things you want to be careful of if you're using electrical therapy is to make sure that you dry the patient as well as the area around the rescue team so that the risk of a shock to you or members of your team have been minimized. Only dry the chest before AED placement. Prioritize oxygenation and ventilation over defibrillation as VFib is rare post-submersion. Don't waste time doing abdominal thrusts to remove water from the lungs, as it may actually cause water to enter the lungs, causing a risk of pneumatic injury. Use suction to clear the airway if you need to, and if BLS airway interventions fail, then move on to other tools in your box for ventilation and airway management. Submersion patients will often vomit during rescue breathing or compressions. Remove vomit using suction, finger wipes, or towels, and consider placing the patient on their side to avoid aspiration if they are breathing on their own. Now, you may often see some foam in the mouth and the airway, and this is mostly going to be surfactant as well as water debris, and this can be pushed back into the lung during ventilation and will be reabsorbed. But again, if you have things that you can suction out, get it out. To prevent alveolar collapse and maintain positive pressure at the end of exhalation, use PEEP. Now, PEEP is always going to be indicated for intubated patients transported over long distances. Your portable ventilators usually have a PEEP setting, and CPAP could be considered per local protocols or the situation on your particular patient. If an endotracheal tube is inserted, also put an NG tube to decompress the stomach. For patients without a pulse, follow your ACLS measures, get your line started, and perform all of the care that you would normally would, even if this were not a drowning patient. Submersion patients can often have bronchospasm. If you hear wheezing, go ahead and give them some albuterol, but don't give them steroids because the submersion injury is what is causing it. It's not an inflammatory reaction as we would normally see in asthma. Prolonged resuscitation, especially in cold water, can lead to unexpectedly good outcomes due to hypothermia, reducing metabolic demands. Always consider comorbidities such as like trauma or hypoglycemia that is in there. Now, again, keep in mind that survival is highly time sensitive. Submersion under 5 minutes has about an 85% good outcome, while over 25 minutes shows poor outcomes. But again, if it's a cold water, we extend that on out. Complications like ARDS, adult respiratory distress syndrome, hypoxic brain injury, multi-organ failure, and sepsis can occur for hours to days after a submersion, underscoring the importance that this patient has to go to the hospital to be evaluated. And most of the time, that's not going to be a problem to get them to go. These symptoms can be subtle or absent, and patients can deteriorate even after they have a fairly long period of stability. Now, again, as we talked about a while ago, the concept of dry drowning is a myth. There's no cases of asymptomatic patients dying hours after exiting the water, nor deaths from drowning more than 4 hours after being minimally symptomatic. Let's transition over into some altitude injuries, talking about diving injuries now. Pressure is defined as force per unit area and can be expressed in various ways, such as 14.7 psi, 760 millimeters of mercury, or 1 ATA, 1 atmosphere. In diving medicine, ATA is commonly used. Water's density means small depth changes cause large pressure changes. Every 33 feet of seawater increases the pressure by 1 atmosphere. Liquids like water are not able to be compressed, but gas-filled organs are indeed compressible. Boyle's law states that gas volume is inversely proportional to pressure, explaining barrel trauma in gas-filled spaces during diving. Dalton's law, on the other hand, says each gas in a mixture exerts the same partial pressure as if it were alone. The total pressure is the sum of all partial pressures. Increased total pressure raises each gas's partial pressure proportionally, explaining nitrogen narcosis, oxygen toxicity, and contamination risk in pressurized systems. Last one we're going to talk about here, relax, we're not going to get too deep into these laws, is Henry's law. Henry's law says that the amount of gas is dissolved in a liquid is directly proportional to the gas's partial pressure above the liquid. This explains why decompression sickness, as you can often see what happens in the water when you open up a carbonated drink. Now, keep in mind that normal air is 79% nitrogen and 21% oxygen. Nitrogen dissolves in fatty tissues and follows Boyle's, Dalton's, and Henry's law. Now again, from Boyle's law, it says nitrogen volume decreases with pressure, increases with pressure decrease during ascent, and this is what causes barrel trauma, is that nitrogen expanding and contracting. Commercial divers use decompression schedules. Recreational divers typically follow no decompression limits. Enriched nitrox gas reduces nitrogen narcosis and decompression illnesses, but increases oxygen toxicity risk. Now, dive tables and computers will guide decompression stops for these divers, but they're not foolproof. Now, there is a condition known as nitrogen narcosis, also known as rapture of the deep or NARCT. And this is caused by breathing compressed nitrogen when you are at depth under the water. At around 100 feet, nitrogen exhibits anesthetic types of properties leading to an altered mental status. Symptoms include euphoria, inappropriate behavior, tingling, panic, and an attempt to do a really, really rapid ascent. Look for signs like euphoria, inappropriate behavior, tingling, panic. Sometimes these patients will actually, if they've got partners that are diving with them, it'll be reported that they've tried to rip either their own or their partner's mask off of their face. Counteract this by reducing nitrogen partial pressure through controlled ascent or using a mixed gas with less nitrogen. Now again, this is not going to affect us terribly much here in Kentucky, but remember, you're going to be tested on national standards, as well as EMS is a very mobile profession, so you may get that perfect job working on the beach, and you'll become more familiar with that. Patients that suffer barrel trauma due to pressure imbalances between gas-filled body spaces and the external atmosphere, especially within the hollow organs of the body. It happens during descent when the gases are compressed or coming back up during ascent, where the gases now begin to expand. Barial trauma affects sinuses, ears, and even your teeth. Breathing compressed air usually prevents barial trauma unless we've got some type of an obstruction, such as like a sinus infection or an ear infection. During ascent, decreasing ambient pressure causes gas expansion in air-filled spaces, leading to reverse squeeze if the air is trapped. Symptoms will mirror those during descent. If the eustachian tube in the ear is blocked and the diver cannot equalize ear pressure with a Valsalva maneuver, middle ear squeeze usually occurs, causing severe ear pain. If the tympanic membrane ruptures, nausea and vomiting and vertigo may follow, especially in cold waters. Now, this can lead to vomiting that will fill up the patient's mask, leading to panic and a rapid ascent, causing a bad situation just to get worse. Treatment includes a loose dressing for ear bleeding and possibly antiemetics or other sedatives to calm the patient down. Symptoms like hearing loss and vertigo may indicate decompression illness and are generally always going to be temporary. An arterial gas embolism is a serious condition that occurs when air bubbles from ruptured alveoli enter the pulmonary capillaries. Now they travel to the heart and then to the brain, causing stroke-like symptoms. Symptoms appear within minutes of surfacing and include weakness, paralysis, seizures, and changes in mental status. If you've got a patient that is suspected of an arterial gas embolism, requires immediate transport to a hyperbaric chamber for recompression therapy. Make sure that you've got a good airway on these patients as far as when you're treating them. Give them 100% oxygen to supplement what little oxygen that they have, and then if you can, make sure you transport them in a supine position. If you feel like that they've got an air embolism, if you'll put the patient in the left lateral recumbent, that will help to minimize the possibility of it moving on into the heart. It's preferential to transport these patients by ground rather than air simply because of the cabin pressures that can change. Get your line started. Treat dysrhythmias like you normally would without any other issues. If you got a patient that has a seizure, use a benzo to help to deal with that. If you've got a patient that is hypotensive, consider a vasopressor. In particular, push-dose epi would be very helpful. Decompression sickness is caused by nitrogen bubbles forming in the blood and the tissues during the patient coming up from a dive. These bubbles interfere with tissue perfusion and trigger chemical changes affecting almost every organ, especially the central nervous system and the spinal cord, due to the fact that nitrogen is dissolved and then reabsorbed within the fatty tissue of the body. During descent, nitrogen and oxygen dissolve in the blood. That comes from Henry's law. And then on ascent, nitrogen diffuses out of the tissues. When a patient comes up really fast, this nitrogen turns into bubbles, leading into decompression illness. Now, there are some specific risk factors. If the patient is overweight, if they're dehydrated, if they've been flying from 12 to 14 hours of diving, especially if they're coming from an area as far as like a high altitude, say like out in Denver, maybe in the Rockies, something like that, that increases the possibility for them. In the past, decompression illness was classified as type 1, which was mild, involving the skin, the lymphatic, and other musculoskeletal systems. With this, these symptoms included joint pain, often causing the bends, mottled skin, fatigue, and occasionally we would see a dysfunction of the lymph system leading into edema from fluid accumulation. Type 2 is classified as severe, affects the pulmonary, the cardiovascular, and the nervous system. A better approach is to specify the affected systems and the precise symptoms that you're seeing. So in decompression, basically, we're going to try to get our patients into a decompression chamber just as soon as we possibly can. We're going to treat our patient normally. Keep in mind that there is a possibility that hypothermia could be involved, so you want to kind of keep that in mind. Now, we've talked about hyperbaric oxygen therapy. Let's talk a little bit more about this for a second. Now, this involves inhaling pure oxygen at pressures greater than 1 atmosphere. And what this does is it reduces the bubble size, the nitrogen content, and it increases oxygen delivery to ischemic tissues. It's used for all types of diving injuries, as well as carbon monoxide poisoning and other conditions. It can often be used to help patients who, especially diabetic patients, who have wounds that won't heal to get better. Now, keep in mind that hyperbaric chambers can turn a simple pneumo into a tension, and it can cause some problems with seizures from oxygen toxicity. It's cautions advised for pregnant patients and those with lung disease or a seizure disorder. Now, bottom line here is that the benefits will outweigh them in the cases of any type of diving disease. Thanks for listening to this lecture. We will continue on with environmental emergencies once you get back into class.